Hello, my topic here is vasopressors in low resource setting. My name is Charat Permikul from Sirat Hospital, Mahidol University, Bangkok, Thailand. I have no conflict of interest to declare. When we talk about low resource, it means that we have limited access to medication, advanced tool, and system because we are a poor country. But it is not true for all because during COVID-19 pandemics, even rich countries have low resource because the number of the patient is high and there are huge need for medication and supplies. And again, lower resource doesn't mean that you have low knowledge and competency because knowledge can be reached anytime, anywhere via IT system. When we have good knowledge and we have poor resource, we can adapt ourselves to use alternative substitution and somehow we can innovate things. Again, like during COVID, we have a lot of innovation and new study coming out. And the most important thing that when we are in low resource, we need to have very good clinical skill and good teamwork and holistic care as well as knowledge. So I will outline here that I will touch basis on physiology of vasodilatory shock, signs of vasopressor, and what and when to use, and use vasopressor with fluid, and example in limited resource area. When we talk about the physiology, we take a look on vascular smooth muscle tone, which is balance between vasoconstriction and vasodilatation. Vasoconstriction comes from the action of calcium that is influx into the cell with the stimulation or action of adrenergic receptor and the storage calcium inside the cell. And with the calcium and the ATP, myosin change to phosphorylated myosin and vasoconstriction happen. In the other hand, vasodilatation happen or occur with the action of ethyl natriuretic peptide, nitric acid, and it come to the process that phosphorylated myosin come to myosin and cause vasodilatation in equilibrium. When abnormal things occur like inflammation, decreasing ATP, increasing hydrogen ion and lactate, there are potassium efflux out of the cell and it causes inhibition of calcium to come in. So there are vasodilatation. So this action is true in inflammation, in prolonged shock with acidosis, but it's not true in neurogenic shock and anaphylactic shock. So the summation or summary of the cause of vasodilatory shock is here. Sepsis is the most important one, followed by anaphylaxis, neurogenic shock, or the extent of inadequate tissue oxygenation or prolonged hypotension in any kind of shock, like hemorrhagic shock, cardiogenic shock, and prolonged cardiopulmonary bypass and some toxin. So when we take a look again on vasopressor, on smooth muscle cell of vascular wall, there are a lot of adrenergic receptor like alpha-1 receptor, beta-2 receptor, dopaminergic receptor, arginine vasopressin, and angiotensin receptor. Stimulation of this receptor gives rise to action of vasoconstriction and vasodilatation. And this adrenergic system have a role and action on other kind of cells also, like in this picture on mononuclear cell. Stimulation of adrenergic system have effect on immunologic action. Different organ or different cell have different receptor on their surface, the membrane. Like the heart have more beta than alpha, blood vessels have more alpha, and vein have mixed receptor, while capillary have no innervation at all. And each vasopressor acts on different receptors, like norepinephrine acts on alpha more than beta, epinephrine acts on alpha again more than beta and more, but epinephrine have more beta 1 than norepinephrine. Phenelphine is very potent alpha 1. Dopamine have action on their own specific receptor on different doses. Vasopressin, terlipressin, and ceripressin act on their receptor, that is arginine vasopressin receptor, and angiotensin have their receptor also, and the action and dose is listed here. So what vasopressor is given in what condition? When we take a look from physiology to and medication to real shock, we can find that each vasodilatory shock or each type of shock have mixed pathophysiology. Like in septic shock, there are vasodilatation. Vasodilatation cause increased vascular space, so there are relative hypovolemia. In some patients may have fluid loss and they have true hypovolemia. In most shock, pathophysiology cause pump or cardiac dysfunction also. So vasopressor should be given in conjunction with fluid or other medication in each kind of shock. But when we take a look at vasopressor agent, in most shock, norepinephrine is the first choice. As summarized in this slide, in cardiogenic shock, truly the treatment of choice is coronary revascularization. But during shock, norepinephrine is needed and is used as the first line. But if there are bradycardia, dopamine can be used. Septic shock, norepinephrine is the first line, and patient with norepinephrine resistant, the vasopressin is used. In anaphylactic shock, epinephrine is used together with steroid and antihistamine. In hypovolemic shock, there are vasodilatation in late phase, and norepinephrine is indicated also. In neurogenic shock, there are a lot of vasodilatation, so norepinephrine is given together with fluid. So fluid is used and together with vasopressor, and in many guidelines from the past, fluid was given first, was advocated to be used first, like in this diagram. In vasodilatory shock, fluid is given and towards the goal of MAP more than 65 or reversal of tissue perfusion. If fluid is not responsive, vasopressor is given. And if norepinephrine is not responsive, you can change to vasopressin or epinephrine, and patient have to assess for cardiac function and correction if there are abnormality. This kind of resuscitation you may face the problem of fluid overload and high mortality, because there are a lot of report and study indicating that patient with fluid overload were associated with high mortality. So later on, fluid was given less and vasopressor was given early and give more. Like 20 years ago, when Dr. Rivers' study came out that early goal-directed therapy, this protocol including what I mentioned before, that is fluid given first until the patient is not fluid responsive as indicated by CVP more than 12, 8 to 12. And at this CVP, if the blood pressure did not return to the goal, vasoactive agent is added. And this kind of suggestion has been on surviving sepsis campaign guideline early. But later on in 2017, one bundle of surviving sepsis campaign came from the retrospective evidence that early vasopressor given may reduce the amount of fluid and reduce the mortality. So their suggestion come from early retrospective work. At the same time, we conduct our study in 2015, 15 that we focus on the early use of norepinephrine in septic shock or sepsis-induced hypotension. The patient at the emergency room who came within 1 hour were recruited and divided into two groups. That is, early norepinephrine group that they received low dose to 0.05 microgram per kilo per min, and while the other group received placebo. So this is a scheme that RCT between early norepinephrine and placebo, and both groups underwent the treatment the same. That was fluid bolus with challenge towards the macrocirculation goal, and if the blood pressure did not return to the goal, open and the patient were not fluid responsive anymore, open label norepinephrine was given. So the outcome of the study was that the early NOR-E group achieved more goal. That is, more of the patient in this early NOR-E achieved the goal at 6 hours more than the standard, and their shock time was shorter than standard NOR-E. While mortality at 28 days were not different, because at that time we focused on primary outcome is that shock reversal. So after that, there are many studies tend to focus on the early use of vasopressor for comparing to the reducing the number of fluid given to the patient. I will give you two examples. The first one is the classic trial group, that is the early restriction or liberal treat fluid in the patient who have septic shock underwent resuscitation not more than 12 hours. And the Clover group, they recruit the patient kind of more early, that resuscitated for not more than 4 hours. This classic and Clover. And they divided the patient into two groups that is restrictive. It means that they adjust vasopressor according to the treatment goal, while the control group or liberal group, they give fluid. It's the same as the protocol that is given for fluid bolus for the patient who are hypotensive if they are volume responsive. The result of the both group, the both study were the same. That was no different in mortality, and in the classic group, no different in serious adverse event. So at this point that we are here, liberal fluid by the use of vasopressor, restriction of the fluid by the use of vasopressor did not help or did not decrease mortality. So my conclusion at this point is here that vasopressor are very beneficial in most kind of vasodilatory shock, and norepinephrine is the first choice, except in anaphylactic shock you use epinephrine. And in sepsis-induced hypertension, norepinephrine should be given early along with fluid, and fluid restriction did not affect mortality, and we need a more way to go on, more study to find out. In limited resource area, what should we do from the standard on all the things that we talked before? In limited resource setting, we definitely we don't have expensive vasopressor and expensive monitoring, and somehow in some area, then we don't have ability to put central line in. So norepinephrine is still perfect if you have it. If not, you can use dopamine or epinephrine. If you cannot put the central line in, and infusion of vasopressor is okay for the low concentration of NOR-E if you use peripheral vein. In our study, we gave early norepinephrine via peripheral vein without increasing vascular complication from that kind of treatment. and it is suggested in the 2021 guideline. And I still believe that early is still the best. That is early diagnosis, early resuscitation of septic shock to be out of shock, early goal achievement, control of infection and source, and post-shock care. Post-shock care is very important because 2/3 of deaths of this shock patient came from post-shock period, not from shock. So we need to take care of post-shock period. And if we don't have good, very expensive monitoring system, we need to have very prudent and very good use clinical side at bedside, use basic monitoring, and we have to use a lot of knowledge. As evident from the process study in 2014 that in that one group they use clinical monitoring, and clinical monitoring give the outcomes the same as the standard treatment. And that is true that a lot of study should be done to find out what is the optimal monitoring of optimal medication. We have example of the treatment of sepsis and septic shock in one rural hospital in Thailand. In 12 years ago, treatment of sepsis was not very updated like here, but in one area there are good referral system. So when the community hospital had a patient with septic shock, they call the referral hospital and they make referral program. But during referral at the referring hospital, they did some common and easy thing, that is take hemoculture, put IV line in, and give the patient fluid bolus, 2-liter bolus, and give them early vasopressor, early dopamine, and early antibiotics. And at the destination hospital, open the hospital bed or ICU bed for the patient. So this is before and after. Before the program, the mortality was 61, decreased to 29%. ICU stay for 3.6, decreased down for 2.2, and the cost was lower. This is a good example of implementation and use basic good knowledge with adaptation. So I touch basics of our things in the outline, like physiology of shock, sign of vasopressor, indication, use with fluid, and the example in the limited resource setting. Thank you very much. ขอบคุณครับ